Hello everyone. Today, uh, it's our special session for the Healthcare AI Forum, and my name is Yuan. I'm the host of the forum, and it's my great pleasure to welcome Professor Nan Liu from Duke NUS. Dr. Liu is the director of the Duke NUS AI Plus Medical Sciences Initiative and co-director of the SyncHealth Duke NUS AI in Medicine Institute. He's also associate professor at the Center for Biomedical Data Science and the program in Health Services Research and Population Health at Duke NUS Medical School. Currently, he leads digital medicine lab, and his research focuses on ethical and responsible AI with applications in healthcare and medicine. Dr. Liu has received research grants from the National Medical Research Council and the National Research Foundation. He was recognized as one of the world's top 2% scientists by Stanford University and elsewhere. And Dr. Liu has also served as the editor for many journals, including NPJ Digital Medicine and PLOS Medicine. And today, we're really glad that he could have this opportunity to come share with us. And his talk will be on the topic of ethical and responsible AI in healthcare, balancing innovation and patient safety. Now, without much further ado, let me turn the stage to Nine, please.
Yeah, thank you so much, Yuan, for your kind invitation and a great introduction. So allow me to share my screen. Can I see my screen in full screen mode?
Yes.
Great. All right. Good morning, everybody. It's indeed a privilege and honor to give a talk today on ethical and responsible AI in healthcare. I'm trying to look into this topic from balancing between the innovation and patient safety. As we know that AI has been really revolutionizing the healthcare industry in the past few years, especially with the introduction of generative AI, large language model, agentic AI. So we all know that AI has really changed our world, and not surprisingly, the AI researchers has won Nobel Prize 2 years ago. Which was very impressive, and you cannot imagine that the AI scientists can win Nobel Prize, but now it becomes a reality. And also that's in our daily lives, that AI is really changing our daily life, especially with the introduction of ChatGPT. Even though technology was available a few years ago, but when the chatbot was introduced to the public, then the technology has really penetrated and entered into our daily lives. So nowadays, I believe the majority of the population have already been using one of the, or maybe some of the large language models and those generative AI tools in daily life. Like myself, I use ChatGPT every day, and of course, I mean, the technology has brought us a lot of advantages and benefits. At the same time, there were concerns with the use of new technology, and not only in scientific research, not only in clinical practices, but also in education, in the daily life, especially for young kids. When there are opportunities as well, there are challenges and the potential issues and matters with the adoption of technology. So the reason that we really needs AI is originated from the availability of a huge amount of data that we have in our current healthcare systems. Right, so in our EMR data, that we have omics data, we have biomarkers, microbiomes, EHR, imaging scans. We also have the linked wearable devices and biosensor data, and also including ambient sensors, environmental data, social determinants of health. There are different kinds of data that's available, and it become more available nowadays with the linked data sets. So such a huge amount of data and also multimodality data give us the luxury of looking to the use of data set to deal with precision medicine, precision health. There are a lot of researchers looking to the use of large data, EMR data for digital clinical trials. So to look into the possibility of moving the patients to home and have a hospital at home programs. Data can be used for pandemic surveillance, and digital twin is a new terminology that has been very popular and widely discussed nowadays. So these are the opportunities that we have nowadays, given a very strong IT support, very large data that we have, especially that many hospitals on Epic that with those very large EMR systems. So there is a possibility of having a linked and a combined data to enable research, innovation, and implementation. So one example is in the past that Singapore is a small country, but we have three large healthcare clusters, and they are on different EMR systems in the past few years. But by in 2 years' time, so all public hospitals in Singapore will be on board Epic. So that's really give us the advantage of have a unified data structure and database that's enable innovation uh, to came across all kinds of data modality and through the connection of different healthcare systems. So a patient with this one hospital, the records is readily available to the hospital, other hospitals, but which was not possible in the past. So AI is not only a fancy word, right? It's according to Deloitte. So this was a report saying that AI potentially can save 400,000 lives in Europe. So the report was in the Europe market, and AI adoption can save about 400 billion euros per year, and that can also save about 1.8 billion hours every year. You can see the magnitude and the scale of the impact that AI can brought into our healthcare systems and community. If you look into developed countries like Europe, US, many other countries in Asia, the advantage and the value of AI is massive. But there are more countries that are still developing, and especially those countries, low and middle income countries, that where AI adoption potentially have even a huge, even a larger scale of impact, because they have much less resources to support their clinicians and healthcare professionals and the patients. But smartphones is very widely available even in LMICs. And if AI can be equipped within the smart devices and mobile devices, so imagine that how powerful this AI can brought into the healthcare systems at the global scale. So next, I will give some simple examples where AI plays a role in healthcare. But before that, I did a very simple search in PubMed. I simply search artificial intelligence in PubMed, which gives me more than 144,000 results. So this number was half about 2 years ago, and so the research and paper has been exponentially increased in the past 2, 3 years. And you can imagine that there will be potentially more than 200,000 papers by the end of this year, and the number will be increasing more and more in the next few years. So the challenge is that the AI, um, although it is not a new technology, but because now we have GPUs, we have a large cluster of CPUs and computers, we have a large amount of data, which has enabled a lot of research and innovation. But how many of such technologies and AI solutions can be implemented in real world is another question. So I will try to share a little bit at the later part of this talk. So one a very popular AI application is called ambient digital scribes. I believe that many hospitals in the States have been using ambient digital scribes widely to enable and to free up the time for the clinicians to have more time to deal with the patients and to spend more time on clinical investigation. So ambient digital scribes, is a real-time transcription and summarization tools. So there are several products that's in the market, and in Singapore there are also some implementation which has already been tested and evaluated in the clinical settings. So although the technology is not very mature nowadays, but we can already see the potential value of implementing ambient digital scripts. But however, according to some reports that even though the technology itself can improve work-life balance, save more time, so that the clinicians don't have to type in everything, and all the reports can be pop-ups automatically. Just some fine-tuning can be done. But there's a risk of hallucination because of the nature of large language models and generative AI. I guess that technology has been improving greatly in the past 2 years, and in probably in the next 2 to 3 years, when AI large language models are more powerful against the ambient digital script, which build upon generative AI, will be getting more and more powerful. So AI has been used as to support and to create clinical decision support systems so for a very long time. You can trace back to maybe 30, 40, 50 years ago. So when some machine learning pattern recognition methods have been implemented and tested in clinical decision support, so AI has been there. Right, so some typical examples, including the IBM Watson, has been working with MSK for advancing the future of a personalized cancer care. And there were also, many other examples. So here I use a review paper to demonstrate that there were a lot of studies and innovation has been using AI and EMR to enhance the cardiovascular risk prediction. So I guess that remember that one slide I demonstrate there were more than 144,000 papers have been published if I simply search AI. And I guess more than 50%, 60%, or even more than that, uh, prediction models. So prediction models has been very well widely uh, tested and created as a tool to support clinical decision support. Um, but uh, but in reality, how many models have been implemented and adopted in real world systems is another question. I will try to touch up that point later. So medical record summarization and coding are other examples where AI can be used. Like UK health data research in the UK have been using AI to make a medical records, and it has been reported to be more accurate and is able to help hospitals plan services. But also there are challenges. That's because of the nature of AI, right? They probably can be used for the coding system, but how can we ensure that the automatic coding will be 100% accurate is another question. So at the moment, at least in Singapore healthcare systems, so all the codings will be verified and conducted by a human being. But in the future, I guess that AI will potentially play a role by speeding up the process, by reducing the workload, to do a kind of maybe a semi-automatic approach will be more feasible rather than a fully automatic approaches for medical record summarization and coding. And uh, and patient communication with AI is another very interesting and more recent application. So this is one example where AI generated draft replies to patient inbox messages. So it's also leveraged on large language model. A very good example and has demonstrated the power of AI. Where there's the communication becoming more easier and more time saving. And there are also a lot of researchers looking to the patient fronting chatbot. So instead of asking a human being, healthcare professionals to talk to patients, so AI large language model can be used to reduce workload and to facilitate patient communication. But I don't have any experience in using such a chatbot, but I had experience with using chatbots provided by a bank for banking services. I was very frustrated with the chatbot because for some questions, AI cannot really understand my meaning and providing me with the correct information, even though I reiterate my questions again and again, and then it's always goes back to the uh, to the beginning of the conversation. So ultimately, I think that I just want to ask for the phone number so that I can call and talk to a real human being. I guess technology is changing rapidly. Hopefully, that's in the future that AI can really have more smart communication skills so that a human can really talk to AI without any frustration. So medical imaging and EMR integration has been there for a very long time. If we look into the data released by FDA, so essentially more than 50% of FDA approved medical device as a AI as a medical device is I think imaging based. So, AI-based imaging solutions has been very popular and still very popular. So for some reasons, right, maybe the AI solutions can be easily generalized. So compared to EMR-based model, so for some reasons, right, imaging is less flexible. So and there are more imaging data and more standardized databases that allow people to have a high quality imaging based AI solution. And also there are many other reasons. So because of the availability of the data and data has been standardized and there are a lot of use cases to support. But given that more data available nowadays, that non-imaging based innovation is becoming very popular as well. I guess in the future there will be more and more non-imaging applications will be available. AI is also be able to empower global collaboration. This is one example that I use as a Mayo Clinic platform, which is a federated learning-based platform that enable global collaboration, cross-institute collaboration without data sharing. Because healthcare data is very sensitive, so the main concern, especially for cross-country collaboration, is the data security and privacy issues. So although there are lots of mechanisms to protect the data, to do a necessary anonymization and de-identification, but yet there are still concerns from a country perspective. For example, Singapore is a small nation. We only have 6 million people, but for data sharing, even the data has been de-identified, has been a challenge, even within Singapore across different institutes. Not to mention about the large-scale data sharing across the border, which is very difficult. So that's really motivates people to think about are there any other solutions that can be used even without the data sharing? Federated learning is one such example, and there are many other technical solutions. AI solutions can be used to empower global collaboration, which is very important, especially as I mentioned earlier, that AI probably can play a very important role in developed countries, but AI probably can provide even more benefit to low and middle income countries and to those low resource setting and environments. So the last example that I want to share with you is a patient outcome prediction tool that we built. This is my own research that we did that in the past 10, 15 years. It is called AI Triage. It's a palm-sized device connected with a tablet where the biosignals, for example, ECGs and PPGs can be collected in real time and the AI will be running on the tablet to analyze the biosignal together with some other information for risk stratifying transplant patients in the emergency department. So this device has been tested and has been evaluated and confirmed to be effective compared to biomarker-based risk prediction models. But there are also some challenges. For example, when we predict a risk of a patient, we probably say, oh, this patient's got a 68% of risk out of 100. But if we present such a number and percentage probability to a clinician, a very immediate reaction is, what does this mean? Right? How can I interpret 0.68 or 68%? So this is something that we have to really think through. So when we build up a prediction model, so we have to, think a little bit deeper on, given we have a prediction model, so what will be the next steps? So is this prediction model useful or not? So we need to understand the clinical flow. So this is the current chest pain patient flow in the emergency department. Usually, patient present to the ED, and there will be initial assessment, 1 to 2 hours wait for the biomarker and chemical kind of testing. And then after that, so for those high-risk patients, we will send them to cardiologists. Otherwise, we'll keep the patients in the emergency room for maybe another 3 to 6 hours. And if patients are really at low risk, we'll discharge patients Otherwise, we will escalate and send the patients to a cath lab or refer to a cardiologist for further examinations. So that was the original clinical flow. And when you introduce a new prediction models, so very likely that you have to change the current workflow, which is very difficult. Right? This is a illustration of how that we can modify the existing clinical flows by integrating the device that I introduced earlier. So within just 5 minutes, we will use the device to replace the original biomarker testing. And so that we can save the time for ranging from 1 hour to 2 hours. For high risk patients, again, we refer to cardiologists. So for the risk patients, that we will have another, 1 or 2 rounds of blood test results to confirm the examination and the risk of patients. So this is a very ideal cases. And we also did some health economic analysis, which demonstrate a possibility of saving $1 million in Singapore if all public hospitals in Singapore are using this new clinical pathway by adopting these devices. Again, I mean, this is a hypothetical cases. You just, imagine if we implement such a model, such a prediction model, then what will happen? What is the benefit? But in reality, there were tons of questions. So I will try to introduce, in a second. So as we see that AI has been really used in research in nearly all medical specialties, in all medical fields. So you can name it cancer, ophthalmology, surgery, diabetes, everything, right? So there were just tons of papers have been published. But when it's come to a real world, application, so we only see a very few number of AI solutions have been implemented. So just look at your own healthcare systems. So you cannot expect that there are, more than 10,000 AI models have been implemented. So otherwise, the whole system will be overwhelmed, and there will be too much, alarms in our systems. We cannot afford the adoption of too many AI solutions. So that leads to some very interesting observation. Here, the number is a little bit updated, right? By 2024, there were less than 900 FDA authorized AI-enabled medical devices, but now the number has been more than 1,000. So it's very similar to the commercial world. So there are many, many startups, but there's a valley of death. So most of the startups may fail during the initial stages of development. Only very few of them will be able to survive. Similarly, in AI space, right? So we have been witnessing a huge amount of AI solutions have been developed, but only a very small number of them have been tested, even tested in real world systems. And only a fewer of them will be adopted and implemented in a daily life in a real world setting, clinical setting. So there are some interesting observations that when we talk about healthcare setting, especially when we do AI innovation. So we always start with data cleaning, right? The data is always messy, right? We can easily see a patient with the age of 200-year old. We can see a patient with 2000 blood pressure. You can see a lot of funny numbers. But in reality, the clinical setting is messy, right? You will never see a very clean setting. So you will see a lot of patients in the emergency room. You can see a lot of beds in the corridors. And this is something that we're facing in daily life. So similarly to the model that we built, the AI solution that we built, if we present some of the solutions to clinician, so these are the questions that has been often asked. So the feedback from clinicians may be simply, I don't really have time to use AI. Right, I'm too busy. I've seen a lot of patients. So if you give me 10 AI models, I don't really know how to use it. I don't have time to use it. And I don't understand the risk value that's in your algorithm. Imagine that I present 80% accuracy, a probability of having adverse outcomes. So to clinician, I don't understand the risk. So what is the cutoff, right? If cutoff is 85, then 80 is essentially is low risk. But to some AI models, 80 is really already a very high risk. And suppose that I'm using an iPad, and how can I connect iPad with hospital EMR system? I'm not very familiar with your own healthcare systems, but in my own system, so it is a disaster to connect iPad with the hospital EMR. That requires a lot of efforts for that connection. It requires a lot of clearance and IT privacy concerns, and also very costly. Right? How can I store the patient data, such as names and ID, into iPad, and how that I can connect that information to EMR systems? And how do I explain the AI output to the patients? So these are the commonly asked questions. I guess that there will be more concerns from a clinical perspective. So I want to talk a little bit on the challenges that especially from AI safety perspective. So this is one example from the UK. So UK has a national healthcare systems, NHS. So they're providing a service where that AI tools generate a set of false alarms, diagnosis for one patient, so that the patient has been invited to do a diabetes screening. But in the end, the patient is afraid of diabetes. Essentially, it's a false positive, which is not bad. But imagine that such a case can happen every day for many of the AI solution because we want to ensure that the prediction is safe. So very, very likely that we will have a lot of false positives. And if there are too many false positives, even a simple error that's made by AI can go to the global headlines. Essentially, I think that the tolerance to any errors made by AI is pretty low compared to a human-induced errors. The other example is quite interesting. A man also in the UK that developed rare condition after ChatGPT query over stopping eating thought. If you have interest, you can read about the news. That is a patient uh, fronting chatbot that leads to some bad outcomes. So you know that ChatGPT just and some other large language model have healthcare uh, versions nowadays, which probably can be more trustworthy and compared to the generic chatbot. But again, I mean, hallucination may occur. The errors may appear. So how patients can responsibly use chatbots and AI, how clinicians can responsibly use them is a very important question. And another example, a report from MIT Technology Review. So during the COVID, um, I think in general, the ethics is at the heart of healthcare AI. If allow me to use this example to illustrate what does this mean, imagine a patient collapse. A bystander, a physician is providing CPR, trying to save patients' life. So at the same time, AI, black box AI, predict the survival chance for these patients is only 1%. So there will be some questions. How does AI make this decision given it is black box? So is this a prediction trustworthy? So whether the real survival chance is 80% instead of predicted 1%. If such a prediction is wrong, then what will happen? So who will be responsible for the wrong predictions? So there will be more questions, but many of the questions will lead the discussion to the ethics. So we published a study to especially look into the ethical considerations by the use of generative AI. But the results and observations can be extended to a generic AI solution. So we look into AI from a different ethical perspective. So there are accountability issues, there were trust issues, there are non-maleficent issues, means no harms. That's AI. So this is the bottom line, your autonomy issues. So these are the ethical considerations that's less technical, maybe more social, more legal oriented. But also there are some ethical aspect that's potentially have an AI solution. For example, if you look at the centerpiece of the figure, that's equity, privacy, transparency, security, and safety. So these are the ethical principles that's very closely linked to AI research, where there are already a lot of technical solutions trying to tackling these challenges. So this is just one example that can quickly go through. Imagine that 80-year-old patients previously in good health, diagnosis with cancer through AI-based screening. So the diagnosis caused a significant anxiety and lead to a decline in the patient's quality of life. So patient and family upload the patient's health records into ChatGPT for medical advice. So ChatGPT recommends surgery. Human doctor gave a warning about the high risk if a patient at 80-year old to do a major surgery. So despite the doctor's warning, patient choose to follow ChatGPT's suggestion, change to an hospital, so went for surgery. So ultimately, patient died. So this is a very simple example that's mimic some of the real situation that we have been observing. And there are a lot of ethical concerns in this simple example. Essentially, it covers all aspects of the ethical path of AI implementation. And if I look into some of the ethical principles I mentioned earlier that potentially have a AI solution, so one part is the transparency of the AI. So if we replace a black box AI model with a more transparent scoring systems, will this change lead to more trust on the AI or not? So there's no guarantee, but maybe to many human doctors and human patients, having a more transparent models can provide you more information that you can understand that potentially can increase the level of trust on AI solutions. But also it is equally important to look at data level of transparency. So there were some international consortium looking to the algorithm biases and promoting transparency in data set, specifically on the data, which is the foundation of any AI models. So biases and fairness has been widely discussed. So if we do not tackle biases at the very beginning of the AI model journey, so such a biases will be aggregated into the algorithm and through additional human introduce the biases and the data, and the biases will be coming back to the data. So imagine that you're building a new model where that they're full of biases within the data, and the model will become even biases. So we have to really decipher so what is happening within the data, algorithm, and human behavior, in order to tackle the biases and fairness issues in the AI implementation. So privacy and security have been also discussed a lot. That we can simply remove patient identifiers, but that doesn't solve the problems. So there will be additional risk and the discussions. So in addition, that if we want to do a collaboration that across different institutes across a different country, and we have to leverage technologies such as federated learning or some other technologies to enable such a collaboration without the risk of data leakage. And when we talk about the safety, we always refers to rigorous clinical validation, right? We can conduct any validation studies, which can be observational, which can be randomized trials or clinical real-world testing. But in addition to the evaluation of the model performance, it is also important to assess the impact of AI interventions on patient outcomes, right? So even your model can provide a better performance, but if patient outcomes remain the same, does it mean that your model is better? So even it is have a higher accuracy compared to the other model, but patients will probably not benefiting from the implementation of your model. But we also need to look into the changes to the healthcare workflow, whether it is feasible or not, and also the resource utilization. If running a model will cost $1 million, will all patients will be benefiting from such a model or not? Is a question. Some researchers even propose that external validation of AI may not be so valid in some setting, maybe recurring local validation, meaning you build a model and you continuously validate your model in your own setting is more important. But having said that, I think it really depends on the clinical needs and depends on the setting where your AI will be implemented. You will decide whether a local validation is needed or an external validation of the model is needed. So all in all, data is the real foundation of AI, right? If you have a low quality data, so there's no guarantee you have a high quality AI solutions. So there were data quality concerns. There were also information transfer. So data has been changing dynamically, especially in some of the Asian countries. That so the population is rapidly aging. So the patient cohort we see today will be much younger than the patient cohort we'll see in 10 or 20 years later. So the data, even though we were using the same EMR system, we will be using the same measuring measures, but the data will be very different. So you build a model today, you have to validate, 5 or 10 years later to ensure that your model are still valid. So that's, leads to a lot of discussions and efforts in building AI governance and guidelines. So there are many, many such guidelines. There was a report saying that existing guidelines, I think globally there are more than 200 guidelines, but which one to use? There are just too many of them. So it's very hard to look into one guideline and to implement it because there will be overlaps across different guidelines, and the different guidelines and governance suggestions will cover different purposes for different clinical use. It's fairly difficult to implement one guideline while that to demonstrate that these guidelines is really valid in your own clinical settings. So in uh, our team that we have been working with a global expert, to do another guideline, unfortunately. But we focus pretty much on AI implementation. It's not for evaluation of AI models, but we hope to have a ethical assessment tool to enable ethical and responsible AI adoption and implementation. So this is something ongoing. Hopefully that we can release the results at the later part of this year. At the government level, there are already many governance suggestions. For example, U.S., Europe have your own AI guidelines. So especially for Europe, they have ethic guidelines for trustworthy AI. Singapore has its own government regulatory body releasing the guidelines on the proper use of AI, including generative AI. But ultimately, these guidelines and governance suggestions are very high level. You have to translate those guidelines into a real world policy. So here I'm just using example from Duke University. So Duke has a algorithm-based clinical decision support oversight framework, which covers the governance of the whole pipelines, the full life cycle of AI, ranging from data preparation to model development, silent trial, evaluation and deployment, also including the implementation. So this is a very good example, I guess, that every hospital, every healthcare system has their own AI governance body. From Singapore side, we're setting up a AI ethics governing council so that we'll be able to evaluate all the AI solutions that to be implemented in the healthcare systems. So they will follow not only have a high performing, not only have a high performance in terms of model prediction, but also it should follow properly on the ethical considerations and to follow the ethical and the responsible use of AI, in order to ensure that model is good, but it also aligns with the ethical principles, right? It can be high performing, but not too expensive. But if your model is high performing, but it's too much expensive, then we probably will not allow such model to be implemented. So with this, I end my sharing. So time is limited, so I'm only able to share some very quick thoughts and insights. So happy to discuss further. Thank you.
Thank you so much, Nine. This is a really important topic, and I really think that you have this comprehensive way of expose the importance of ethical AI because there is so much AI system that gets into clinical use. And I wanted to start asking the questions about specifically for the care AI that you just talked about. So this ethics assessment tool provides a structured framework for evaluating AI implementations. In your experience, talking about or maybe talking with the physicians about deploying this across different institutions, what is the most important and most common tension between what the frameworks recommend versus what organizational stakeholders are willing to accept?
Yeah, sure. Thanks. I think it's a very important question. So I think that I mean research should be able to provide as much information options as possible. But for example, for using Care AI as one example, we try to be comprehensive so that Care AI aims to cover all ethical principles. For example, safety issues, fairness and biases, and the transparency. But having said that, if you talk to different leaderships in individual organizations, not all the leaderships and the organization will be agreeing with all the ethical principles. So I think that it is important as an academic research efforts. So we try to provide a comprehensive tool, but we are not requiring that the user to follow all the principles. We're not requiring the users to adopt all the options. So maybe just for an example, maybe a US hospital very concerned about the fairness and biases issues, but in Asian hospital, maybe equity is less important. Accuracy is more important. Maybe privacy preserving is more important. So I think we leave the decision with individual organizations instead of saying you have to follow everything. And also in reality, it's nearly impossible for one AI solution to fulfill all the ethical principles, and that will be impossible. So I think we have to in real clinical practice, we have to balance the feasibility, the efforts that we put into AI implementation, and the benefits of such an implementation.
Yeah, so thank you for presenting a comprehensive framework while also trying to give the organizations flexibility in terms of balancing different components and in a thoughtful way. And I also want to follow up on your work that you mentioned about the triage, right? So this emergency department triage prediction work really represents high-stake decision points, right? So AI recommendations directly influence resource allocation, care urgency. And so when you benchmark these triage models, how do you think about the asymmetric cost of different error types? Let's say under triage, false negatives versus over triage, false positives. And especially in resource constraint settings, have you encountered situations where optimizing for overall accuracy actually worsens outcomes for the most vulnerable patients?
Yeah, thanks again. So I think the chest pain case is a very unique clinical cases because of the high mortality rate is challenging to implement such a model. And to be frank, that we have been seeing a lot of barriers for implementing this model in real clinical setting. Because even though we have demonstrated the potential benefits of time saving, the cost saving, but on the ground, clinicians are still preferring having more tests, more rounds of blood tests to ensure that the patients is really at low risk, so that they will be able to discharge the patients. So I think it is something that I think is very hard to use dollar and cents to evaluate, right? So in terms of so it is the clinician would rather that spend more time and more money while keeping the patients in hospital, but the only criteria for them is to ensure patient is safe. I think that this is something, I guess many AI solutions that are dealing with a high stakes decision making will always have such a dilemma. And that's, in my opinion, that explains the reason for many of the successful AI implementation actually are for patient screening purposes, which are considered comparably low, risk AI implementation. So if you missed out the one screening, patient will not die immediately, but the patient will still have time to be, for another round of screening, and the disease can be detected, and the disease progression can be slow. But for high stakes decision and for acute setting, for example, emergency and acute care ICU, I guess that is becoming more difficult to implement AI solutions.
Yeah, totally reasonable, Nine. And I want to close the session with the final questions. That's kind of the classical enough data question. So, given your extensive work with federated learning and multi-site collaborations, so when do you think that we have enough data to safely deploy a clinical AI system? Is it purely a statistical question, or maybe are there qualitative considerations about data provenance or diversity or representativeness that should gate the deployment decisions?
Yeah, sure. Thanks. I think it's quite interesting because in some of our own work, we found out that actually federated learning is less attractive, less effective because given the data, the sample size that for each institute they have, which is large enough to have a fairly good model using local data to build which bring us the attention that the federated learning may not be so effective in many cases. But having said that, if you look at a low and middle income countries, especially some of the low resource setting, I think federated learning, maybe together with transfer learning, can be really useful since it's maybe easy for us to collect the data like 10,000, 20,000 easily in like your system in Singapore, in Europe. But it's becoming very challenging to collect such amount of high quality data in rural areas in India, in some parts of the in villages in Vietnam. And given that scenario, if we are able to collect a small sample from local, but we can transfer the knowledge that we learn from developed environments, and through federated learning, we can safely transfer and translate the knowledge and the model to a low resource setting. I guess that the value with the federated learning will be more powerful. But for those very developed environments where you can easily get a large sample size, I guess the value is slightly lower.
Thank you, Nai. I wanted to close with this special gratitude for you to come today and share with us all the amazing work that your team has done and also your deep insights on the topic of AI ethics and governance. And this has really been inspiring to a lot of I think, the trainees that we have here. And also, I think this could be a opportunity to start some collaboration. So thank you again.
Thank you so much for having me. Thank you.